All right, let's get started back with our outcomes management section. This will include point of care, care validation, a little bit of auditing, just to get you familiar with how the system works, how it flows from the time of the referral. So we left off last time, we had just entered in a new referral and scheduled our evaluation visit. And like I said before, with the actual way the process works is from the time of the referral, we'll complete the evaluation and admission document at the same time. That would then go into our care validation section for review to make sure that it's billable. As soon as the visit gets passed through care validation, we will automate the turning your referral into a patient account. Generally, we will automatically create your episode or cert period, automatically create your plan of care, and then your responsibility then would be to schedule visits for the remainder of that cert period, and the process just continues from there. Nurses or therapists would complete their routine visits. Those visits would get turned into care validation. Care validation checks them to make sure that they're billable. When they get passed, the schedule automatically gets updated and we're ready to bill our claims. Okay, so let's run through the general point of care program documentation, clinical documentation system. We call it point of care. You can do this offline or online. We're going to work as an online nurse right now. Whenever you log in, if you're a clinician, the system on the dashboard would show you your list of visits. Lindsay, let's go to our point of care program. If we just go to schedule, point of care. It would give us a list of all of our visits that are currently assigned to us. We evidently don't belong as anyone in the system. Let's go ahead and set somebody up. All right, so now as a nurse, if I were to log in to the online system, so there on my dashboard, it's going to list out any of the visits that I currently have scheduled this week. I can either click on one of those visits or I can go to schedule and point of care. That would pull up my entire list of visits. All right, now what controls the visits that show up on this screen? A couple of things. One, the visit has to be scheduled via the add charge screen. So either add charge from the schedule, you would pull up our add charge screen that we saw earlier. That visit status has to be in either scheduled or unconfirmed status. Okay, Lindsay, will you open up another tab, pull up the add charge page or edit a charge? If you'll scroll down, you'll see our status listing here at the very bottom. Okay, click on that drop-down box there. Just so you understand how the system processes visits through the entire point of care, scheduling, billing process. When a charge is first scheduled, we leave it in scheduled status. In our system, that means that the visit has not been completed, it's not been touched yet. Right? It's waiting on a nurse or a therapist to start the visit. When the nurse or therapist completes the visit in our point of care program and synchronizes if they're offline, we will automatically change that status to unconfirmed. Okay, unconfirmed means somebody's performed the visit, but we haven't set it to be billed yet. It hasn't been through care validation. When it goes through care validation, when it gets passed, we'll automatically set that status to confirmed. Confirmed means that the visit's been done, we have proof of delivery, and it's ready to be billed. Right? As soon as it gets billed, it will change to a billed status. There are two other statuses you should be aware of. If you need to write a visit off without it being billed, you can choose either revenue adjusted or uncollectible. Okay, they do the exact same thing, but they serve two different accounting functions. Revenue adjustment means this is a visit that we never expected to get paid for. Okay, it should never have counted toward revenue in the first place. Typically, these are going to be your training visits, orientation visits, for private duty nursing, evaluation visits, right, that you don't get reimbursed for. They can still go to payroll, but we never expected to get paid for them in the first place, so we're going to write those off to revenue adjustment. When we set up our services earlier, there's a field that says status when confirmed, or when passed through care validation. You can automatically set some of your visits to go to revenue adjustment or uncollectible. Uncollectible is a status meaning we wanted to bill this particular charge, we expected to get paid for this charge, but we can't bill it for some reason. Generally, that's going to be because we didn't get orders. Okay. Right, so I can't bill this charge because it would get paid, but I don't have an order for it, so I'm going to have to write it off, although I had originally expected to get paid for it. That goes to uncollectible. The other status is missed visit, which is exactly what it says. When you cannot make a visit for one reason or another, you can write it off as a missed visit, and it won't be billed. All right, so in order for a visit to get onto our point of care device, it has to be assigned to us, and it has to be in either unconfirmed or scheduled status. All right, let's go back to our point of care program. All right, by default, it's going to give me a list of all of the visits I still need to perform. You'll notice that there are some, there are dates that are in the past. As long as a visit is in scheduled or unconfirmed status and it's assigned to me, it will always show up here, right? It could be 2 years old. It's still going to show up on this list. Hopefully that's not the case, because that means we have some data entry issues. We should have written it off earlier. But just know it's always going to show up on your device until it's out of one of those two statuses. By default, this is listed according to date. What controls how far into the future we download visits onto your device? Under the security group for this particular nurse or this particular user, there's a field that actually asks how many days to download to your point of care device. So depending upon your type of agency and type of user, you may want to control that pretty strictly. So for private duty nursing, we generally recommend that be no more than 2 days. For pediatric therapy, that could be up to 2 months. For Medicare nurses, we generally would recommend something like 14 days. Okay, so you get 7 to 14 days. So you'd get a listing of your schedule from today, everything before today, and then up to 7 or 14 days in the future. All right, across the top, you have some ways to choose what gets displayed. By default, we display only the visits that you need to work on, that are waiting on the nurse or the therapist to work on. When you finish a visit and you say that it's completed, we will hide it off of this screen and display it on the care validation screen. In care validation, if you fail that visit to send it back to the nurse, we're going to hide it on the care validation screen and display it on this screen automatically. Something to keep in mind, it actually exists in both locations. Okay, just because it's hidden doesn't mean it doesn't exist, and you can still show it and display it. So I can always go to that link that says show confirmed visits, and that would pull up visits that are currently in care validation that I've finished up. I can limit it to today's visits, past due visits, all visits, which is what we're currently looking at, and I can change the way the system orders those visits, either by date, by patient, or by task. All right, let's look at our Oasis start of care visit that we scheduled earlier. For Maggie May, you see our note that we keyed in earlier that said the dog bites. This particular visit is highlighted in this pink fuchsia color to let us know this is the first time this patient has appeared on our schedule. When you start a visit, it will change to this darker purple color and say that it's in process. If it's in red, it means that care validation has failed that visit back to us to make corrections. If it's in green, those are generally hidden from us, but green means that I've completed the visit and it's currently waiting on care validation to validate that visit. All right, let's click on our Maggie May visit here, and you'll see that it expands and it gives us the information that we keyed in earlier, which I guess we didn't save when we were keying it in earlier. It will give us our phone number, our address, the DNR code, those OBQI codes that we had keyed in, that reason order field that we said would go onto our progress summary, the diagnosis codes that came from the referral screen. We can get a listing of our actual medical records, so if we had communication notes or that referral to a third-party provider, that would be listed out as well. So pretty much everything we need before we begin our visit. We get out to the patient's home, we're going to click the Start Visit button. And that's going to pull up our clinical documentation. Now, we're not going to go through a full assessment. We'd be here all afternoon going through every type of record. So I'm just going to point out some of the more involved areas of the system you need to be aware of. Every point of care document follows the same process. The very first screen will let you document mileage and travel time, the start date and time of the visit, generally what type of visit you're performing. If we're dealing with pediatric therapy or private duty nursing, it'll ask us what type of visit. If you choose discharge as a type of visit for those, or on your routine visits, it will give you the ability to create a discharge summary later on in the visit. So that's one thing to keep in mind. If we choose that this is a missed visit, then it will display missed visit information, so you can fill that out, and that will update your charge when the visit gets passed through care validation. And instead of printing out a skilled nursing note, it would print out a missed visit form. You can move through the categories in point of care. By default, we have set up the visit in categories that should mimic the way you're actually assessing the patient. You can get to those sections by clicking the green arrow. You'll have forward and backward arrows depending on what screen you're on. We automatically save the information that was on the previous screen as soon as you click the arrow, the forward arrow, the back arrow, the checkbox, or the X, or if you quickly jump between categories using that drop-down box. Okay, so lots of ways to navigate to different categories. In general, we recommend you start at the beginning and just hit the forward arrow as you're filling out information. When we get to the very end of the visit, if we're done documenting and we're ready for this visit to go to care validation, we would click the green checkbox arrow. That's going to validate our visit to make sure that we've completed everything that needs to be completed. Go ahead and click that, Lindsay. You'll see, since we haven't completed this OASIS, we have a ton of errors and warnings. Okay, throughout the system, when we do our own validation or system validation, you'll see two types. Warnings mean that we're fairly certain something's wrong, something looks amiss, but in certain circumstances, it's okay, right? So we're just giving you a warning to let you know about it. You can fix it or not. Errors mean, without a doubt, there's a problem with what you're doing, so you have to correct it. If you have an error message, you won't have the ability to submit your visit. Within point of care, if we give you an error or a warning, you can actually just click on the the message there, and it will take you back to whatever page that error exists on. So you can fill those things out. Within most of our point of care program, most of the fields are going to be highlighted in just this orange color. As you go through it, though, you'll notice a few fields that go to like the pain section or ENT. You'll notice like M1200 is in green because it affects your payment calculation for your Medicare OASIS. So this field actually would go into the PPS payment calculation, and you'll see that we added a little green check next to the fields or the answers that could potentially get you additional reimbursement, or that at least affect that calculation. We can't tell you what those are going to be because it depends on a number of other factors like early or late episode, how many therapy visits are being performed, because you have 5 different calculations for Medicare. Let's go to the gastrointestinal section. Scroll down. Keep going. All right, nutritional requirements. You'll notice that those are in this aquamarine color. Those fields highlighted in that color mean that they will go onto our plan of care. So if we have a separate plan of care document, any of the fields that are highlighted in that color will relate or carry over onto our plan of care. So nutritional requirements, safety measures, etc. Okay. For the most part, all of the answers, like I said, we're not going to go through a full assessment, but just understand that they're all fairly simple. They're designed around the idea that we are answering every required or necessary assessment. So like with our nutritional requirements, if there are none or if they're within normal limits for the patient, you should always have those options available to you. Just select the boxes that are applicable for that particular assessment. You have an other or comment box at the bottom of every page that you can fill out. So again, fairly straightforward with how the actual assessment is completed. Let's talk about some of the fields that are unique outside of what you're accustomed to with just a normal assessment. Let's go back to our homebound assessment and benefit eligibility. On any of the evaluations where homebound could be an issue, obviously Medicare, any type of adult services, this is what we talked about at the very beginning of the class, where we want to make sure that we're going to get paid for rendering service to this patient. Okay. Again, most documentation systems would simply ask you homebound justification and have 6 or 7 check boxes, and they'll have that on every single document. And it's very easy to have that undermined, that medical necessity or homebound status undermined by an auditor. What we've done is actually added in a full homebound questionnaire. So we start making sure you've checked the insurance card. Have they been served by another home health agency in the past 2 years? If so, who's that agency? So we can work out transfer information. What assistive devices does the individual use for transferring or ambulation? Scroll down. We want to know about special transportation devices. Can they drive? Are they able to drive? Are there medical restrictions for leaving the residence? Do they require assistance leaving the home? By the time you get finished with this questionnaire, you've hit on all of the items that Medicare requires when evaluating homebound status. So at the very end, you can simply answer, is the patient homebound or not? Does the patient meet the requirements of the Medicare benefit? Again, we're doing an OASIS assessment, so that would be particularly beneficial here. The idea is that we're establishing homebound and medical necessity right off the bat. Every visit then afterward is designed simply not to undermine what we've already done. Okay. All right, let's look at the pain assessment. There's another category where we go pretty in depth because pain in particular is in some of our marketing materials, we use pain as the leading cause of suicide. It's the #1 cause of physician complaints. It's the #1 cause of lawsuits, right? Unaddressed chronic pain. So we want to make sure that that's fully assessed on every patient. So you have patient's current pain level. What was their pain like in the last 24 hours? You have your several different pain scales that are available to be utilized. So we have those listed out. That FLAC pain scale for patients who are non-responsive, or if you want to compare their non-verbal pain indicators against the actual verbal indicator of pain will help you assess whether the patient accurately identifies with their own pain level. If there's any falsification for one reason or another. Full pain assessment, right? Nonverbal pain indications, medications that get administered to help offset pain. Let's go to the medication screen. Med profile, excuse me. Click on the Med Profile button. You'll recognize this screen. It's the same as the screen we had in the online system. Again, if the medications were keyed in back at the time of the referral, like they were, you'll see that they automatically show up here and can be edited. We can add medications. We would want to click on the, down at the bottom, we would want to click on the menu button to complete an actual medication review. This gets attached to the back of the med profile. And addresses contraindications, etc. All right, go ahead and close that. Let's to the ICD-10 diagnosis codes section. Okay, when we're assigning out diagnosis codes, obviously we had on our summary screen the diagnosis that came from the physician. We should have the diagnosis code from their inpatient procedures, etc. At this screen, we can simply type in the diagnosis code if we know it, or we can click on the magnifying glass in order to get a listing of diagnosis codes that apply for this particular patient. For Medicare, it would be important for you to notice the next to the last column lets you know if this is a case mix diagnosis code or not. Obviously, case mix diagnosis codes would potentially, under your calculation, could potentially increase reimbursement. You could type in a description. So if you were looking for diabetes, you could just type in DIAB, hit enter or search. Diabetic code, just choose the one that's most applicable. Right. Choose a severity, put in a diagnosis, onset, or exacerbation date. And then you'll notice we have these up and down arrows. These are available on the point of care device or in care validation. So once your diagnosis codes are assigned, if you need to recategorize them, it's as simple as just clicking those up and down arrows to reassign them to the different prioritization levels. All right, let's look at the care plan section. Plan of care. Plan of care. We're going to go through a validation procedure to make sure everything has been entered correctly. If that passes, if we're done with, if everything has been entered correctly, the very next screen that shows up is going to be different depending on what type of document we're looking at. For Medicare, for our PPS or OASIS type documents, we will pull up a PPS analysis screen. Within that screen, we will show you the case mix calculation, the HIPS code, the estimated payment. If your user group has permission to view financial information, we'll show you the actual payment that you should expect for that episode. Okay. Lindsay, can you pull up a patient that we can get into their care planning section? May even go to care validation. Do we have any that are already confirmed? Just click on the show confirmed visits. Nothing. Well, if you go into care validation, do we have an OASIS What about that admit visit there? Let's go to the plan of care. Edit plan of care. All right, this is the screen that would show up in offline point of care. It shows up under care validation as well. Again, this is for adult OASIS visits. Just want you guys to understand kind of what we're doing and why, okay? We're gonna give you the patient name, the CBSA code, right? The county that they live in and whether that qualifies as a rural CBSA or not. The RFA 01, start of care. This falls into the early episode, 13 or fewer visits calculation. So it's a first category calculation. Your clinical points, we've allocated, or based upon your input, you've received 11 clinical points in that calculation. We're letting you know that's 2 above medium, and you're getting these points. That's the most you can get under this scoring equation. You're getting 4 points for therapy at home, 1 point for vision, 5 points for pressure ulcers, 1 point for bowel incontinence, nothing for diagnosis codes. I do point that out because it's still a habit in home health to place so much emphasis on diagnosis coding because of points, even though diagnosis coding now very seldom affects your payment much at all compared to obviously functional and service scores. So you can see in this case, we're high clinical calculations with no diagnosis code help at all. Scroll down under functional. We have 5 points here, which puts us in a low category. We're 1 point below the next payment tier. We had 2 points because of dressing the upper or lower body, 3 points for bathing. I mentioned that we don't put that in terms of dollar amounts, right? Because we don't want anyone incentivized to up code or down code. But the reality is this would be a perfect example of a case that I would want a therapist reevaluating the answers that were put in by my nurse, right? I'm 1 point below a different payment tier. I only put in 4 therapy visits, which doesn't make much sense at all because, you know, from a Medicare perspective, until we get to that 6th therapy visit, we're not getting any payment for those. But those in particular, right, our therapy tiers. If you guys are using outsourced therapy companies, they're notorious for what? Two times a week for 4 weeks, 8 therapy visits. 8 therapy visits mean we're giving away a therapy visit with no reimbursement for it. And so that's what we're telling you right here, right? We're 2 below medium. For therapy visits, those actually are visits. So we're 2 visits below the next reimbursement scale, which in this case is several $100s, okay? So you want to be pretty skilled at reading this particular analysis. NRS, your non-routine supply points, we're at medium-low here, so we're 12 points below the next threshold level. Our HIPS code, our HERG score, it evaluates to a case mix, so you can see we actually have a really low case mix score, 0.6737. From a generic management perspective, you know, as a company, we would be shooting for case mix averages in the 1.1 to 1.3 range. A 0.6737 definitely brings up questions about medical necessity, right? With very few functional limitations, we're going to have problems justifying homebound status and medical necessity for this particular patient. The reality is, I think we said the patient has a stasis ulcer, they have pressure ulcers, but there are other things obviously that we're not documenting to go along with that. All right, our full calculation, if you have financial privileges turned on, we're telling you exactly how we're calculating it. So you can see we started out with an episode payment of $2,869. Based upon the calculations that we run, we end up with a payment of $1,667, right? Supply payment of $143, which is actually pretty good because we're dealing with wounds. But altogether, we're getting $1,800 for this episode. So as a care validator or a care planner, I need to be aware of what I can, if that's what I'm getting reimbursed, to make sure that we're profitable under this particular scenario, right? Scroll down, our additional OASIS analysis is going to let you know about other things that we may have identified. So in particular, patient has a case mix below 1, which raises your risk of a financial audit. If that is an occurring theme or a recurring theme at your agency, that you have low case mix patients. So please review your ADL section, the patient's diagnosis codes. Obviously, we also let you know about the therapy visits. You still need a physician order for those. All right, let's hit continue. Let's assume we've done everything correctly at this point. I'm assuming, oh yeah, we went to a different patient. So we have our diagnosis codes listed out here. For this one, we only put cholera. So obviously we weren't great in our documentation. This would list out all of our diagnosis codes. Those would be checked by default. We also have the Medicare OBQI process management guides that they're looking for. So if our patient has pressure ulcers, or if they're at risk for falls, we want to make sure that we're teaching on those as well. So for this patient, we know they're going to have a pressure ulcer, so we want to check that. We probably want to check that they have pain, and we're going to want to look at their medication management, in addition to care plans that are associated with their diagnosis code. Hit continue. What we're doing is walking you guys through the creation of an actual care plan. We set up our discipline frequencies. So skilled nursing, somebody actually typed these out, 1 time a week for 6 weeks, therapy twice a week for 6 weeks. If you're going to start care later than the current, the start of the episode week, you can actually say when you want to start that care if you're pushing it off. Scroll down. Based upon what we put in these frequencies, our care plans will be displayed for those disciplines. We can click Show Our Calendar. So as we're establishing our frequency, this gives us our calendar for that certification period. So we can see, right, we're starting the episode on a Thursday, so trying to get in 2 or 3 visits. At most, we could do 3 visits that week, but that's going to mean we're working on that Saturday. We could easily allocate out our frequencies by looking at this schedule. Go ahead and close that. Send note to scheduler. Let's click on that. All right. One of the goals of the system is to make it where you don't have communication gaps. Okay. By default, if I'm a nurse and I complete my plan of care, my scheduler doesn't know about that, right? Unless I call her or unless she's somehow monitoring the system. What this allows you to do is let the scheduler know the things that you know when you're in the field. Patient prefers visits on what particular day, what time of day. Let's say this patient likes Monday, Wednesday visits early in the morning. We would choose early morning, and then in other notes, we could put in patient has a doctor's appointment on December 25th, etc. And that information will show up on your schedule for your scheduler to see. So when your scheduler goes to schedule for this particular episode, they'll see all this information, they'll have your orders, and they'll have your goals right there on the schedule. Hit continue. Hey. This lets you set up your vital sign parameters. They default to that provider vital sign parameter section that we set up on the provider screen. Simply choose and put in the parameters if you want them to be patient specific. Scroll down. Any other information you want at the top of the order section on your plan of care, you can type in that box. Continue. All right, now we're going to build our plan of care. We've established the problems on the previous screen, the diagnosis codes and those process measures. Now we're trying to identify what goals for care we want to reach this cert period, and what assessments, instructions, and procedures are going to be required in order to get us there. Okay, these will be listed out by diagnosis code. You guys can create your own care paths. We have several already in the system, but you can create your own underneath the reference files, interventions. Okay, we'll show you how to do that here in just a second. But if you, let's say you do a lot of wound care, or maybe you treat low vision patients, or you name it, whatever that condition is, you can set up your own interventions and care paths in the software. Those will show up here automatically. So let's just click the common link at the very top. These are ones that are common to all patients regardless of their diagnosis. Pain is going to be decreased, right? We can key in that level. Patient will have a decreased risk for falls by, and it asks you to insert the date. You can simply type those in at that point. Okay, you have some that are diagnosis specific, so as we scroll down, you'll see each of those blue bars has it limited to these different areas, like our pain assessment and mitigation, or pressure ulcers. Well, for some reason we're not seeing any. Click on all interventions. Okay, we'd be able to choose which goals are appropriate for that particular patient's condition. On the very last section, you have custom. That would allow you to simply type in whatever you want for that particular patient. Okay? So we set up our goals, then we hit next. And we're going to do the same thing with our assessments. The next page would be instructions. The next page would be procedures. Let's go to the instructions page. All right, click on Common. We're designing the system so that not only are we creating your plan of care, but on your routine notes, your plan of care is automatically incorporated into the treatment plan on the note. Okay. Most documentation systems, especially hard copy documentation, when you have an instruction section on the note, it's really just a big box where people write out whatever they want to write. Okay. Even in most point of care systems, it's just a box that people can type into. The problem with that is a computer system and definitely a piece of paper, we can't guarantee that what they taught or the procedures they performed relate in any way to that patient's condition. We can't prove that they were ordered. None of that stuff happens automatically. Even if it is applicable to our orders and our diagnosis code, we can't guarantee that it isn't the same teaching over and over and over again. One of the big problems you may have recently read about is OIG's been cracking down on canned documentation, of course, which they've never liked. But you've seen several systems where you have like this copy forward feature, right? You complete one visit note and then every other visit note defaults to what the previous note said, and you're expected to just change information. Well, notoriously, what always happens is the same instructions, the same procedures happen every single visit note. We end up teaching on the same topics, and when you go through an audit, there's no medical necessity after that first or second time of teaching that information. Okay. We've tried to eliminate all of those problems by the way we implement our care planning. So for instructions, we're going to choose, number one, our instructions are very, very specific. Okay. Traditional home care would have a big blurb on the plan of care that says skilled nurse to instruct on the diabetic disease process, including signs and symptoms, medication review, like 20 different things, right, on this blurb. Well, what happens, number one, it's hard to fulfill everything that's in that type of order within one episode. Number two, even if you are able to, you have no justification for a recertification, right? If your patient's diabetic with CHF and your plan of care for that first episode basically had you teaching everything about diabetes and CHF that first episode, you don't qualify to do that the next episode. Right? So we say a lot of audits where the first episode isn't questioned, but every subsequent episode is disallowed for lack of medical necessity because the plans of care look identical, and CMS is assuming that you rendered that care in the first episode and don't have medical necessity for any subsequent episodes. So we solve that in a number of ways. Number one, we make our teaching very specific, okay? Instead of saying we're going to teach on all of these things, we're choosing very specific. So if we'd had diabetes up here, you would have 20 or 30 different instructions applicable to diabetics. Skilled nurse to instruct on the signs and symptoms to report to the physician. Skilled nurse to teach on the effects of diabetes on family members, the effects of diabetes on your medication regimen, etc. You'd have a ton of those. We would expect for that first episode that you're going to choose 5 or 6 of those instructions for your primary diagnosis code. In that text box, you're going to tell us how many times you want to teach that particular topic. Okay, so for ones that like teach on the definition of diabetes, not that important. I'm probably going to maybe teach on that once, and I want to make it a low priority. Risk factors that we need to look out for to communicate to the doctor, I may put that, and I may want to teach that 2 or 3 times depending upon the mental status of my patient, and I'm going to put that as a high priority. So what we're doing is we're automatically assigning out priority levels, kind of setting the ceiling on redundant teaching. We're making sure that our teaching is tied back to our primary diagnosis. I would go to my secondary diagnosis and I would choose in my first episode, and I may choose 1 to 3 things to teach on there, okay, and leave it at that. I may go down, depending upon how many of these other treatment guides I have, I may pick 1 or 2 of those, okay, depending upon how many visits. So if we had $1,800 that we're going to get paid for this visit, I know in this case I have to do a lot of wound care, but on a general patient, I may be looking at stacking my visits during that first 3 weeks so that I have 2 visits the first week, in this case 3 visits the next week, 2 the following week, and then 1 time a week thereafter, depending on how my wound care progresses. Okay, so I know I'm going to have 5, 7, probably 12, 13 visits for this particular episode. As long as I have my cost under $130 per visit, I'm going to be profitable for this particular episode. Okay, so I would have 6 to 9 instructions, right, to be able to teach 1 of those on every visit in addition to my wound care, and I would hit continue. When we come back to this page on our recertification visit, it's going to do a number of things. Number 1 is any of the topics that have already been taught on in previous episodes are going to get highlighted in red to let you know we've already addressed those. So now, even if my patient's condition hasn't changed, but they still have a need for home health services, I can now have a plan of care that looks completely different than the previous plan of care, because I can move on my primary diagnosis and teach on topics 10 through 16, and on my secondary I can teach topics 3 through 6. I can focus more now on my CHF, right? And when you look at our plans of care, they both relate directly back to my diagnosis code, my condition of the patient. I have medical necessity. Nothing has been redundant, right? It all ties out. It gives me the ability to have extended episodes of care, and actually my patient end up getting better care because we have very specific interventions that we're performing. It also allows us to keep from having the strict, if you guys have seen like actual care paths that are used like in a hospital where it's, or you know, first visit, it used to be this way 20 years ago in home health, first visit you have to teach this, second visit you have to teach this. It's very, very strict, which didn't work when you walked in, your patient had a fever or they had a fall and you needed to change it all up. This still gives you the flexibility. If I go into the patient's home and what I'm supposed to be teaching on or the next thing in my list is the definition of diabetes, but I walk in and my patient has 103-degree fever and they can't get out of bed, I can move back up and reteach on a topic without that being an issue and document why I did it, right? On my recert visit then, or my recert plan of care, those topics are going to be highlighted in red so I can just move on down and select the next interventions, instructions, procedures that need to be worked on for this particular patient. Then it will take us, if we put in any home health aid frequencies, it'll let us create our aid care plan. And then it's going to take us to this last screen where Medicare asks about does our plan of care address those process measures that we looked at on the very first screen. It gives us the ability then to pull up a summary of our plan of care. We can call our doctor right then and there, get our verbal order, start a care date, sign off on the plan of care, hit confirm, and we're done. Okay. Private duty nursing is similar to that in that we would create a plan of care, but it's designed around a flow sheet, right? What we're going to be doing every 15 minutes or every hour for that patient. Pediatric therapy is designed around goals, long-term, short-term goals, and other orders. But the idea is still the same, right? Establishing medical necessity right off the bat for every single certification period that we work with. All right, Lindsay, let's go back into that visit. We can do it from here. If you just go to field validation, go to drop in the category there, drop down to our care coordination page. All right, I just put in here how to communicate with other people. So when I'm in the field, I can actually create a communication note. Go ahead and click that Create Communication Note. This is that same event that we saw earlier under the patient screen, but it allows me to say what I've done. This communication note is a separate document that goes into the patient's medical record. So you can simply fill that out and that automatically goes to anyone else who is involved in the patient's care. When they can go to complete their next visit, they'll see that as part of the patient's medical record. All right, you can close that. All right, so when we're done with a visit, so the last couple of screens would be the patient, receiving the patient's signature on your device. The last page is the nurse's signature, end date and time. They click that green check mark, it validates again. They hit submit and it gets turned into our care validation team. All right, so we finish up our visit, click the green check mark, visit disappears from our screen, we synchronize. It's going to go into our care validation screen. All right. Let's talk through a couple of things. One, let's go back to that process flow we talked about earlier, right? Medications, physician orders, communication notes are automatically getting routed wherever they need to go. The visit note itself, which may include our plan of care, if we're doing an evaluation visit, if we're dealing with the PDN evaluation, our 24-hour flow sheet, auth forms. If we're dealing with therapy evaluations where we may have a TP1 or a TP2 auth form attached to it, all of those documents stay together and go into care validation. All right, so we don't generate the TP1, we don't generate the CCP flow sheets, we don't generate the plan of care until the visit gets passed through care validation, because all of those documents are required to be in sync with each other, right? We wouldn't want to create a plan of care and then you go back and change your OASIS clinical documentation maybe change your diagnosis code, because in your plan of care and your assessment visit are going to have different diagnosis codes. So all of those stay together. I bring that up, one, so you know the process flow, but two, because you need to be really careful with time frames, right? The number one bottleneck in our software, especially for new agencies, is a misunderstanding of the care validation process, okay? It's designed to help you, not hurt you, clinically and financially. Our biggest problem is that agencies, especially new agencies, start to treat care validation as an auditing process, okay? And I need you to understand you will be very quickly in financial and clinical pain if you misconstrue the two. Care validation is not auditing. Care validation is designed to make sure you don't have clinical adverse events that are occurring, and primarily that visit can be billed. Okay, that's its number one goal, to make sure that visit can be billed. If that's an evaluation visit, a subcontext of that is to make sure that the entire episode can be billed, right? That our plan of care justifies medical necessity, homebound status, whatever else our payer may require. But care validation is primarily a billing function. Our clinical functions are secondary to that, and they're primarily associated with urgent issues, right? New or changed medications that may affect our scheduling, communication notes that display a problem, vital signs out of parameter. It's not designed, and I'll keep repeating this, not designed to be a QA or auditing process. What we see a lot of agencies do, now that they have the ability to audit every note, they will go into care validation and start felling visits back because of misspellings, because we didn't document edema, because the communication section on the note wasn't filled out according to policy. Okay? Those are all great things, wrong place to do it. If you try to audit in care validation, you are going to end up, number one, bottlenecking your billing, which means your cash flow is going to suffer significantly. And number two, you're going to bottleneck your clinical operations, because everything else, like visit number 2, depends on visit number 1, right? I can't really do my next skilled nursing visit when my plan of care hasn't been created, when my evaluation visit hasn't gone through, okay? So if it's taking, and if you'll look in our compliance complex book, we give you time frames that you should be meeting as an organization for completing and passing OASIS documents, evaluation visits, routine visits, in order to maintain an optimal clinical and financial organization. But if you try auditing those records, right, number one, your nurses are going to get really frustrated because they're getting all their visit notes filled back for these seemingly mundane issues, even if they're valid issues, right? Yeah, I should have assessed edema. You're right, I should have. But in order for that to happen, right, if you fell that back, number one, I've now delayed billing by multiple days, right? If I'm synchronizing once a day, I did the visit today, I synchronized it to you. You didn't care validate it until tomorrow. You failed it, right? I didn't get it that morning because I synchronized tomorrow morning. 2 days later, I synchronize. Now it comes back to me. I fix it, even if I'm on the ball. I fix it that day. Then I synchronize the next morning. You get it back in care validation, and then you pass it. We're 4 or 5 days down the road, right? Because of edema, right? Because I left that. You're going to catch that in your quarterly audits. That's what your quarterly QA, your random sample of charts, is designed to do, not what care validation is designed for, okay? Care validation, like I said, primarily making sure the visit, and for eval visits, the entire episode is going to be billable. So for Medicare, I'm looking at to make sure that my patient is homebound and that I documented that correctly. And every visit, I'm looking to make sure we have medical necessity. Okay? We give you the ability to look at the entire visit, the entire medical record if you want to. Just don't get overzealous with it, right? Look at that homebound. If we're going to QA that start of care assessment, I'm looking at that homebound assessment page. I'm looking at my plan of care, right? And maybe like my vital signs, I may check a couple of other pages. If we had wound care, I want to look at those. But aside from that, I'm not holding it long term. Most of my care validation process for an evaluation, we're looking at 15, 20 minutes tops on average. On routine visit notes, we should be sub 2 or 3 minutes, right? This isn't a very difficult process. Routine visits for most visit types, there's enough QA in the system automatically. If we did our plan of care correctly, they can't turn the visit note in unless they've documented a procedure or an instruction, right? And so as long as I'm looking at those, the system's guaranteeing that they did document an instruction or a procedure. I just have to look, make sure it's on my plan of care, pass it through, okay? Again, I guess I should give the disclaimer, that's not legal advice, it's software training advice, but understand that is the purpose. And if you do it any other way, you'll run into a lot of headaches that are unnecessary. All right, so our care validation process, we go to compliance, care validation. It takes you to this menu. Depending upon your personal preferences, it'll either take you to this menu or to our current version. It's actually the older version. Let's go into the current version of our care validation screen. It gives you a list of all of the types of documents that are ready to be validated. Let's click on that Oasis Start of Care. You see we have 6 of those ready to go. Just click on it. It gives us a list of all of our patients. If it's been failed back to the nurse already, it's going to tell you what those comments were, why it was failed back. All right, by default, we are showing you guys just the visits that your care validator needs to look at. Okay, meaning the nurse has either turned it in for the first time and it hasn't been validated, or it's been validated and failed and they've already corrected it and sent it back to you. Okay? So all we have to do is click on the date of service to pull up our care validation screen. On the left-hand side, a lot going on this screen. It's important that you know what every piece does. On the left-hand side, the type of visit, the patient, it was scheduled for August 14th. It was performed August 14th. There's the date and time. You can see it was from 1:30 to 2:30, so it's about an hour-long visit performed by Lindsay. It fits within the current episode here. Our payer is Blue Cross. These are our validation options. Okay, most agencies, this validation status is really the only one you're concerned with. That controls the entire visit, whether it gets ready to be billed or whether it goes back to our nurse. For larger agencies that want to split out the care validation process, if you want somebody who's only responsible for checking compliance, maybe someone else who's responsible for diagnosis coding, someone else who's responsible for creating your plans of care, you have that flexibility, okay? I say that with the warning that if those are split out, you need a lot of coordination and very strict protocols because you don't want each of those taking multiple days, okay? Even in those scenarios, you wouldn't want your compliance person auditing or care validating, sending that back to the nurse, waiting on it to come back before your coder looks at it and then sends it back. Then your plan of care sends it back. You'll be 20 days, right, getting a plan of care out the door. So you need very strict protocols on how those are audited and at what time points. The validation status is the main one that we're looking at. All right, the right-hand window here, scroll back up to the top. At the very beginning, we're going to give you any warnings or errors that we've identified. So we're going to let you know, like right here, you've got 9 goals for this episode, which is pretty excessive for a 60-day certification period. So we just want to make sure that you've reviewed that, you're aware of it. For OASIS documents, we give you the ability to export that OASIS right here. That's not an export or a transmission to CMS. This is if you wanted to use like a third-party validation system like a PPS Plus or a Home Health Gold to further scrub your documentation, you can. For the most part, all of those warnings and validations already built in the system, but we do give you that as an option. We are letting you know that somebody's already created another OASIS for this document, or for this particular episode, so you want to be aware of that. That shouldn't happen really ever. Then we give you that same OASIS validation or OASIS analysis screen that we looked at before. All right, so in this particular case, no therapy visits, high clinical, medium functional. We're 1 point below our next bump up on our functional points. But looking at it, we do have poor ambulation. Our ability to dress the upper or lower body is not great. Bathing is really not great. And yet we have no therapy ordered for this particular certification period. Scroll down. You'll see our case mix 0.82. So still not great on medical necessity there. So we're giving you the warnings again. Our start of care date isn't within 5 days of the assessment. And we let you know about other areas of the document where we have problems. Okay, so here's our summary errors warning screen. If we had communication notes, vital signs out of parameter, those things are going to be alerted. It will alert you here on this screen. Field validation gives us the ability to go into the note and validate individual fields. Again, use this with extreme caution. This first screen here, since we've already QA'd this or care validated this before, it's letting us know answers that we have changed. It's very important that you understand what's taking place on this screen. We are not changing clinical documentation. All right, there's two really big policy issues. Okay. And these are things that you probably want addressed in your medical records policy. Number one, we are not changing your clinician's documentation. Okay, only the clinician can do that. We are making recommendations on a duplicate or ghost copy of their record that they can either agree with and make the changes themselves, or they can disagree with. And number two, this is not part of the medical record yet. Okay? State policy or regulation here in Texas requires that if you make a correction to a medical record, you have to line through it and initial. These are not part of the medical record. We don't have them as part of the medical record until it passes care validation. Okay, so we're not making corrections. Our nurses are not making corrections to their documentation. This is still a collaboration. We're still in the process of creating the document. In order to do that, or once that's done, when we're doing our care validation, as we go field by field, if we make recommended changes, those are going to show up on this screen. It will tell you what your current answer is for whatever that field. So for M1340, the current answer, meaning what the nurse had put on her document, if we pass this visit right now, it would show a 1. Somehow we changed the answer to a 1. Not a very good example, obviously. Typically that would be different. One of the drawbacks to using a fake database to do things in, to train with. The validated answer is, oh, I know why. Actually, it is a good example. The validated answer, meaning the answer we asked the nurse to make, is also a 1. The reason they're the same is because you can see in that next to last column, accepted by clinician, we've already fed this back to the nurse and she actually accepted our change. Okay, I don't know what the original answer was, but she since changed it to match what we requested. Okay, if she hadn't, it would say no, right? And we would have her actual answer there. That comment section allows us to send a note back to the nurse for that particular field, maybe saying why we're asking for that correction. She could also send us a comment as well. So if she disagrees, she can send a comment saying, no, you're wrong and here's why. You can delete that out. If you hit the red X, it will delete your recommendation out of the system. At all times, that current answer is what is actually in the medical record, right? If we were to pass this right now, that's the answer that would go into the medical record. If you hit the visit note to print this out, it's going to print what's in the current answer. All right. Another caveat to remember about our care validation section is that it's designed to only go back and forth once, okay? Meaning a nurse completes her note, she turns it into care validation, we should do everything then and then fail it back to them, okay? Don't get into a habit of the back and forth game, right? Number one, because it's going to kill cash flow, finances, all the other stuff we've already talked about. Number two, because we didn't really set the system up to work that way. If they've accepted your answer already, and then you decide, oh, I didn't really want them to make that change, I wanted it to be something else, you can't just go back in and change the answer. In this case, let's say they put a 0, we recommended it be a 1, we send it back to the nurse, she says, okay, she changed it to a 1, you get it back and you say, no, I actually meant a 2. You change it to a 2, you send it back to the nurse can't accept that answer again because she's already accepted your previous answer. If you're going to do that, you have to hit this unaccept link on the right, okay? Again, should really never be used except in extreme circumstances. Be careful with it. You're not going to hurt anything, it's just bad procedure. But if you want to send, if a nurse has already accepted your answer, but you need to make corrections to your own recommendation, you have to hit the unaccept option first, okay? I mentioned that, and it sounds kind of stupid for me to bring it up in this training so much, but you would really be surprised at the number of calls we get where people are saying, the nurse accepted an answer, but it's not showing up. It's not showing up. Almost every time it's because of this. Because they had already accepted another answer, they can't accept the answer again. So whatever you see, that's why I bring it up again, whatever you see in this current answers column is what is on the nurse's documentation right now. All right, so let's actually do some care validation. Let's click on the Validate Fields button. That's going to take us into the visit note. Again, we see a ghost copy, just what the nurse keyed in, unless we've overwritten it. Right? If we override it here, we're looking at our ghost copy, it's going to show us the answer we put in, not necessarily what is going to be on the documentation if we passed it right now. We can make any changes that we want on any of these fields. Change that date assessment completed to the 15th. All right, hit the green checkbox up top. It will validate this assessment as though your answers, right, to make sure you're giving good answers as well. Looks like we didn't fill out some things. We'd need to, let's fill those out. M22, 1022B. It's because we gave a priority, a severity, without putting in a diagnosis code. Take out M1024, column 3. So you can see this is a bad care validator, putting in incorrect information. All right, close that. All right, hit submit. So we validated successfully. Now you can see all of the fields that we changed, right? Diagnosis, M20, 1022B, the current answer is blank. We changed it to cholera. 1022C, column 4, one diagnosis code, we've now made it blank. Again, if we pass this visit right now, it's going to put the same information that's always been there. We can send it back to our nurse who can now accept those other options, right? I like this because this is exactly what a visit would look like if we had already failed it and it came back to us. The ones in yellow are letting us know that the nurse never accepted those answers, okay? So you should, the key to this, your initial care validation for an OASIS assessment, 15 to 20 minutes, right, tops. A visit, couple of minutes, tops. When you're revalidating, meaning it's been failed to the nurse and now it's come back to you, it should take you seconds, right? Because this is the screen that'll pop up by default. I can look here, as long as everything is in white, I know that the nurse did exactly what I asked them to do. If any field is highlighted in yellow, I know the nurse didn't do anything, right? She did not accept my changes. If they show up in red, it means they accepted my changes, but now they're different than what I recommended, okay? I mean, if I told her to select a 1, she accepted it, but then went in and changed it to a 2. Usually that doesn't happen. Where that comes in most of the time is if we key into like a comment field, right? It's one of the beauties of this. I can go into a comment field and say, I need more comments here, right? Or tell me about this. So my nurse sees it, she can accept it. Well, then I expect her to actually erase my comments and type in comments of her own. If that happens, it's going to show up in red. All I have to do then is look here and it's going to say, my recommendation was, give me some comments. Her answer should be a bunch of comments. I can see that she did exactly what I asked to be done. All I have to do is pass. I don't have to go back into my visit. I don't have to validate any of the information. As long as they did what I asked, I know they're in compliance with my previous recommendations. All I have to do is hit my validation status, set that to pass. The other tabs across the top only show up on our evaluation visits. Coding and plan of care, they're just quick jumps to those particular sections of the visit. Visit note gives you a printout of your actual medical record for this document according to what the nurse currently has within the documentation itself. There's one other tab that can show up on pediatric therapy visits, I think adult visits as well, and that's a supervision tab. That's designed so that if you have a CODA or a PTA, the supervisor can validate that visit and actually sign off on it, and that signature will go into the note. Right, so it just helps you with the supervision section.